Eldrigo Namaskara. COSCON is going live this year. Thanks to the circumstances, we have learned to modify. And how else to begin a conference? We have Dr. Nagaraju sir, Professor, Director of Minto and Regional Eye Institute. Sorry. Who is here with us?
Not director.
A beautiful program for the PGs and beginners. Over to you, Nagaraju sir.
Good morning, everybody. Thank you, Dr. Ellen, and thanks to all the members of Karnataka Ophthalmic Society for giving me an opportunity to host this postgraduate program. Our postgraduates had a sort of uneventful academic year in the past 2 years because of this COVID issue, and basically we have designed this PG program into 7 modules, keeping in mind the examination going postgraduates in mind. Actually, we have got around 7 modules. We'll be beginning with the cataract module, and it will be followed by the cornea module, the optics module, the neuro-ophthalmology and squint, oculoplasty, glaucoma, and the retina module. Each module will be having a lecture, an exhaustive lecture on a few topics which are important to the postgraduates, and we have planned to have the discussion at the end of each module. After all the talks are over, there will be a discussion, and people who have got any doubts can just on the chat box over there, you can just type your queries, and it will be answered by the speakers or whoever the speakers who are there, and they will be answering all the queries which you have got. And we would like to start with the cataract module. In the cataract module, we have got 4 talks. One is on phaco-dynamics by Dr. Shilpa Kodakani, and pediatric cataract management by Dr. Soumya R. Murthy, and small pupil management by Dr. Savio Pereira, and management of PCR by Dr. Preeti Manjunath. Can the event management team take over from now? Shall we begin with the talk by Dr. Shilpa Kodakani, phaco-dynamics? Dr. Deeksha and Dr. Vidarthi, my faculty here from Minto Hospital, they will be coordinating each sessions, and they'll be coordinating with the speakers and the event management and the audience, and the answers will be taken, compiled by them, and they will be answered at the end of each.
Very good morning to you all. First of all, I would like to thank the organizers for having given me this opportunity to talk on this very important and fundamental topic, phaco-dynamics. Let me share the screen now. Phaco-dynamics is the physical and the biological principles which are involved in the emulsification and aspiration of the cataract. There are 3 basic elements in phacoemulsification, that is irrigation, aspiration, and emulsification or cutting of the nucleus with the help of ultrasonic power. And this is achieved with the help of a foot pedal, where position 1 is irrigation, position 2 is irrigation and aspiration, and position 3 is irrigation, aspiration, and phaco. And be it any machine, whether it is a basic one or the most advanced one, these 3 elements are what form a good phacoemulsification. And for this, we have a handpiece which is connected to the irrigation and the aspiration tubings, and it has an electrical connection for providing the phaco power. Now, irrigation is gravity driven because higher the bottle height, deeper will be the anterior chamber, and it is usually 60 centimeters from the level of the eye. To achieve a good, stable anterior chamber, we need the fluidics of the machine to be good. What does it mean? It means that the inflow or the infusion should always be more or equal to the outflow or the aspiration. So irrigation and aspiration have to be working hand in hand to be able to give you a good, stable anterior chamber. Now, the bottle height, in certain situations, we may need to change the bottle height. We may need to lower the bottle height in conditions like high myopia or in glaucoma, because in glaucoma with raised bottle height, the intraocular pressure can increase and can compromise the optic nerve. When you have a PC rent, this infusion can go with high pressure into the vitreous and churn the vitreous, and the vitreous can come up into the anterior chamber through the rent. Now, high bottle height is required when you have a shallow anterior chamber, like in hyperopes or an intumescent cataract or a narrow angle glaucoma. The aspiration is basically defined as the evacuation or removal of the fluid through a closed system. It is determined by these two concepts, which are flow rate and vacuum. The flow rate is measured in cc's per minute, and it is the measure of how quickly the fluid can come out into the aspiration port. And mind you, it is unoccluded, whereas the vacuum is basically the holding power of the tip, and that is measured in millimeters of mercury. And usually the vacuum will build up once there is occlusion of the tip by the nuclear fragment. This is how a flow rate will help to bring the pieces towards the tip, and once the nuclear fragment occludes the tip, this is where the vacuum starts building up. More the vacuum, stronger is the hold of the nuclear fragment, and a negative suction pressure is created by the pump, which is attached to the aspiration line. Now, these pumps are either peristaltic, venturi, or diaphragmatic. It is the peristaltic which is most commonly used and more safer because it has got a pump with rollers, and these rollers, when the aspiration tubing goes over these rollers, it pinches the tubing and it helps in milking the fluid forward. And once this pump, when the flow rate is high, this pump will move faster. Now, in a venturi or a diaphragmatic pump, it does not wait for the vacuum to build up. And so sometimes it could be a little dangerous because it can pull not only the cortical matter or the nuclear fragments, it can pull also the PC. Now, in a peristaltic pump, more the flow rate, faster the pump will rotate. And once the tip is occluded by the nuclear fragment, the vacuum starts building. The rollers slow down. The outflow or the aspiration level decreases. And on complete occlusion, the rollers come to a complete stop and the outflow approaches zero. And this is the time that the vacuum is at its highest. And once this tip gets occluded, you will hear that ting, 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 ting sound on the machine, which means there is complete or total occlusion. And then you can use your phaco power. So in short, a non-occluded tip will have a high vacuum, and there is, a low vacuum and high flow rate, whereas when the tip is occluded, there will be high vacuum and the flow rate will be less. Now we need to understand what is surge. It is basically when the nuclear fragment comes and the tip gets occluded. If the tubings are compliant and not very rigid, there is a negative pressure which is created inside the tubing. Once the or the nuclear fragment is emulsified, this energy which is inside temporarily will pull the fluid from the anterior chamber, and the anterior chamber can collapse just for a fraction of a second. And this is what is called as a surge. It is the situation when the outflow of the fluid from the eye exceeds the inflow, even if it is just for a fraction of a second. This can be dangerous because once the anterior chamber is shallow, PC can come up and you can end up with a red. This is prevented by something called as venting. That is, when the vacuum reaches its maximum preset level, a vent valve will open and some air or fluid will enter into the system so that this collapse is prevented and the surge is prevented. Now, phaco power is the ability of the phaco handpiece to cut or emulsify the cataract. It has got piezoelectric crystals which are excited by electrical connections. And this electrical energy is converted into a mechanical energy whereby the tip begins to move or oscillate. It is measured in terms of percentage. That means if it is a softer cataract, you can keep the phaco power less to about 20 or 30 or 40%, whereas if it is a harder cataract, you can even go up to 80 or 100%. It is measured in terms of frequency and the stroke length. Frequency is usually 35 to 45,000 cycles per second, depending on the machine. It is always fixed. You cannot change it. And it basically means how many times the tip travels in a second. The stroke length is how far the tip can travel. So more the stroke length, more will be the phaco power. And this is changeable depending on the grade of cataract. Now the stroke length is how much the tip can move forward. The tip also has got different degrees. A 0-degree tip will have more holding or can create more vacuum easily, whereas the cutting will be less. Whereas in a 45-degree tip, it will have better cutting, but will be able to hold the piece less easily. So these are the different types of tips which can be used in different grades of cataract. Then you have the jackhammer effect, which is basically a physical force that which helps in when the tip and the nuclear fragment come together. You also have cavitation, which is when there is a backward movement of the tip, it causes low pressure, causing microbubbles. When it moves forward, it has high pressure, which causes compression of the microbubbles, which will implode. And once this imploding occurs, there is energy created, which is the cavitation effect. And this is also important that during the backward movement also, there is energy which is created, which helps in phacoemulsification. Longer the stroke length, the possibility of the tip which moves forward will push the nuclear fragment away and cause a chatter, or the nuclear pieces can rotate very freely into the anterior chamber and can also cause turbulence. So this is something that can and should be avoided. So increase in the stroke length is basically increased phaco power, which can generate heat, cause wound burns, and damage to the corneal endothelium. You can modulate the power with the help of phaco pulses or burst modes, by which harder cataracts can be emulsified with less amount of phaco power. And this is how the tip will oscillate in a traditional, which is a longitudinal phaco, but to reduce chatter and turbulence, you can have something like a torsional oscillation, by which it will not push the tip or the fragments away. So to recapitulate, you have the irrigation, the aspiration in the form of flow rate and vacuum, and you have the phaco power to be able to do a successful phacoemulsification. Phacoemulsification is basically like driving a car where you have the foot pedal. That means you accelerate and you have the clutch in a car. Your hand piece is basically your steering, which help, and your parameters, which help you in giving a good phacoemulsification. To translate into surgery, this is what is sculpting, which is going on. This is a hard cataract. In sculpting, you do not need much of vacuum or flow rate, but you need better cutting. So here your phaco power will be more, but it need not have more flow rate or vacuum. But when you are chopping the nucleus, this is where you will need more vacuum, but only when you are chopping, you need not have more flow rate, because you don't want really pieces to be coming close to the tip. You just want better cutting and you want better holding at this step. Later, of course, once you have made the pieces, This is where again, because it's a hard cataract, you need more phaco power. And here you need more of flow rate for the pieces to come towards the tip, and also better vacuum to be able to hold the tip properly and emulsify the nucleus. Thank you so much. Thank you for a patient hearing.
Thank you, Dr. Shilpa R. Kodakani, for the wonderful talk. The next talk will be on management of pediatric cataract by Dr. Soumya R. Murthy, who is a consultant in the Department of Pediatric Ophthalmology and Strabismus, Shankara Eye Hospital, Bangalore. You can play the next video.
Very good morning. Very good morning to everybody. At the outset, I would like to thank the COSCON team for inviting me here. Today, I will be speaking on management of pediatric cataracts. The pediatric cataracts are an entity on itself and needs more understanding and cannot be an extension of an adult cataract surgery. The talk would be discussed on the following headings in terms of investigations, the parameters of importance, the IOL power calculation, the surgical technique, and the post-op rehabilitation. The most important thing is the varied morphology of cataract, which could vary from a zonular cataract to a sutural or a blue dot cataract or a posterior lenticonus cataract, or it could be a zonular cataract with riders to a partially absorbed membranous cataract or a total cataract. This varied morphology helps us choose which of the cataracts to operate, which of it should not be operated. Investigations in case of a bilateral cataract begins with the history and a family history of cataract being there in parents and a dilated examination of both the parents to understand if there is a cataract. A routine blood investigations in terms of a hemoglobin, complete blood count, TC-TCSR for the GA fitness. What is recommended to note the etiology is the torch titers, VDRL, and urine for reducing substances. The rest of the investigations are basically optional. In a unilateral cataract, there is no need to do a systemic investigation, and the etiology is usually found on a detailed posterior segment examination. In case of a unilateral total cataract, an ASOCT helps in noting the integrity of the posterior capsule. Most important for the postgraduates to understand, there is no need for any systemic investigations in a case of a child with unilateral congenital cataract. Once we know the investigations what are to be done, we should understand what are the parameters of importance. Most important to record the corneal diameter, both horizontally and vertically. Any corneal diameter which is less than 10 mm is a contraindication for an IOL implantation in a child. IOP and gonioscopy, axial and keratometry, important to record the IOL power calculation, and also for the axial length in case of microphthalmia gives us an indication in terms of it being a cause of associated with PFE. Pachymetry or the corneal thickness and a detailed anti and fundus examination. All this to be done detailedly under anesthesia or if the child is cooperative in the OPD itself. When to operate largely depends on the morphology. If the cataract is total, if the cataract is dense zonular, if the cataract is in the posterior capsule, it needs surgery. If the size is more than 3 mm, the presence of strabismus or nystagmus also needs a surgery. Age of the child, the critical age is usually between 6 to 8 weeks in a bilateral cataract. In a unilateral cataract, it's between 4 to 6 weeks of age. IATS is a landmark study which gave us guidelines about when to operate in a unilateral congenital cataract. What they concluded was that whenever we are operating on an infant younger than 7 months of age with unilateral cataract, it's important to give them a phakic and rehabilitate with contact lenses, and primary IOL in less than 7 months of age should be reserved only for select infants. To implant the IOL or not, in a unilateral cataract, the guidelines came from IATS where less than 7 months was not recommended. After 1 year, it is usually recommended. In a bilateral cataract, the age cutoff is usually about the age of 1 year. In experienced hands, 7 months to 1 year of age, based on the individual decision, it can be done again. IOL power calculation, the formula to choose largely depends on the age of the child and also the size of the eye that we are measuring on. Holiday 1 and SRK2 formula gives equally good results and had the best predictive value in infant eyes. What we normally use is NAD formula, where the age of the child plus the post-op refraction should give us 7. So we aim a refraction of +3 post-operatively in a 4-year-old child, which serves a +6 target refraction in a 1-year-old child. or in the Hans formula, which is 20% undercorrection in less than 2 years of age and 10% undercorrection in more than 2 years of age. The need for primary posterior capsular access cannot be overemphasized. It has to be done in all the children along with anti-vitrectomy when the age is less than 6 years. It can be done as a standalone procedure without anti-vitrectomy in 6 to 8 years of age. When the age is more than 8, you can always do just PPC would not be recommended. Now let's go to the surgical technique. This is a procedure, this is a lensectomy being done in a 3-month-old child. In a lensectomy procedure, we don't do the tunnel, we just make 2 side ports. After that, you use the cutter to complete the entire procedure. And there's a butterfly cannula is used for the irrigation to give a watertight seal wound when we are operating. When we are doing the anterior rhexis with the cutter rate is usually kept low at around 200 to 300 with adequate vacuum. Once the cutting of the anterior capsule is complete or the anterior rhexis is complete with the cutter, we go ahead and move the aspirate the cortex with the same cutter without removing it or using a IA cannula. Once the cortical aspiration is complete, we do a PPC also with the same cutter and finish off the anterior vitrectomy. Most important in lensectomy is the anterior capsular opening and the posterior capsular opening are of equal size, so both of them fuse and form and don't allow the PCO to develop into the visual axis. So the anterior axis and posterior axis are of the same size in an infant when you're doing a lensectomy. Once we complete the procedure, we suture the wounds with a 10-0 Vicryl to 10-0 nylon. It's important to get a watertight seal wound. When we're looking at primary IOL implantation, the procedure varies. We can either do a scleral section or a clear corneal section. Here we are doing a scleral section. As we see, it's a zonular cataract. Important to stain the capsule in a pediatric age group, primarily because the stain adds on to the strength for the anterior capsule. The capsule is very elastic. This rhexis is usually done with the help of a utrata or an intraocular microrhexis forceps, as what I'm using it here. Once and using of a high molecular weight substances helps to do the anterior rhexis with ease. Once we finish off the rhexis, we do the cortical wash in a similar manner as what we normally do in any other softer cataracts. This is followed by PPC. Here I'm making a neck and then doing the primary posterior capsular rhexis with the microrhexis forceps. When, as we plan to put an implant an IOL in this particular child, the PPC is usually a millimeter smaller than that of an anterior rhexis. 1 to 2 millimeters smaller helps in inserting the IOL with ease. This is followed by the vitrectomy, where the cut rate is usually kept around 800 and 150 vacuum. This is followed by the IOL implantation. Here we are implanting the hydrophobic single-piece acrylic lens. So this is implanted in the back between the anterior and the posterior rhexis. So now when we have understood how the procedure is done, the material of choice in a child is usually a single-piece hydrophobic acrylic. In a sulcus placement, it's usually with a 3-piece hydrophobic acrylic or PMM. The post-op rehabilitation plays a very important role in children. When post the surgery, if the child is less than 1 year, we give a refraction as a single vision class. It's usually given if the refraction comes around +12, you add a +3, that is +15 as a single vision class is given to the child. When the child gets older, the addition is much lesser, +2 to +3 in 1 to 2 years of age and +2 in a 2-year-old child. When the child starts walking, we shift them over to our bifocal lenses. Apart from giving the glasses, what is important is to initiate patching according to the age of the child. At every follow-up visit for the child, you look for the refraction of the child. Is the refraction changing? What is the intraocular pressure? What is the ocular alignment? Is there any visual axis of education? If so, is it visually significant? Should we do something about it? And fundus examination. So all these parameters are to be recorded every visit, and the child needs a lifelong follow-up. So before operating any pediatric patient with a pediatric cataract, it's important to convey this information to the parents in terms of this requirement. The child would need glasses post-operative, would need a lifelong follow-up. Take home, dilated eye examination of parents is very important in a child to avoid unnecessary investigation. If it's an autosomal dominant hereditary cataract and we see that the parents are having the similar kind of cataract when we dilate them, we don't need further investigation. Systemic investigations are important only in a bilateral congenital cataract. Cataract surgery is just a first step in visual rehabilitation. Most important is to have a post-op refractive correction. The post-op refractive correction, when not given properly, is actually more amblyogenic than the cataract itself. So the post-op refractive correction is the important step in pediatric cataract surgery. Unless we're committed to do the long-term follow-up of the child, we are not justified in operating any pediatric cataract surgery. So for all the postgraduate students, it's important to understand that you tell all these parameters. When you do an IOL is basically based on the parameters and the age of the child and the IATA study. Thank you very much.
Thank you very much, madam, for this very informative talk. Let's move on to the next speaker, Dr. Savio Pereira. He is a senior consultant at Netradhama Super Speciality Hospital, Bangalore, and his topic will be management of small pupil.
A very good morning to everyone. On the outset, I would like to thank COSCON for giving me the opportunity for being a part of the target exam program. My topic for today will be phacoemulsification in small pupils. This is generally asked in the examination as a long question and also in the practical viva. So what is a small pupil? So by definition, any pupillary diameter which is equal to or less than 4 millimeters is defined as a small pupil. There are different types of small pupils. It could be either hyporeactive or a fixed, which is anatomical small pupils. The common conditions which result in a small pupil are myoptic therapy, like patients with chronic angle closure who are on pilocarpet, fluid exfoliation syndrome, diabetes, posterior synechial, chronic uveitic cases, post-surgical states, or any trauma, Horner syndrome, any conditions which cause dilator atrophy, such as herpes simplex, should be aware of and should be mentioned. The most likely complications that occur because of small pupils is a PCR and vitreous loss because of poor visualization. It can also result in a dropped lens fragment, incomplete cortical cleanup, and very often the pupillary margin gets aspirated into the phaco probe. This can result in iris shutting, post-operative inflammation, and distorted pupils. And patients are more likely to experience pain in these types of cases. So a very important part is a thorough preoperative examination. There should be a good slit lamp examination to see if there are any pectoral areas of iris atrophy or diffuse, presence of posterior synechial, pupillary membrane should all be mentioned. After putting a dilatation drop, either atropine or putting tropic acid plus, the maximum dilatation should be noted in the OPD. And also, assessment of the hardness of cataract becomes very important in these cases. The anterior chamber depth is important because the more lesser the anterior chamber depth, the more chances of corneal endothelial cell loss. And also, visualization of pigments or guttae on the corneal endothelium should be noted. So, how do you tackle a small pupil? You have viscomydriasis, paniculitis, stretch pupilloplasty, which can be attempted, and various types of pupil dilators. Now, sphincterotomy, which was done earlier, should be avoided because it leads to a permanently fixed dilated pupil, which may lead to phocoemesis. So, the other techniques which are described brings the pupil back down once the surgery is completed. Yes, it is sometimes with an irregular margin, but it is more acceptable cosmetically. So what are the important steps that need to be taken care of when you're doing phacoemulsification? All the parameters should be lower than your usual settings. You can do a vertical chop, which is a type of direct chop, rather than doing a horizontal chopping. Because horizontal chopping, there will be poor visualization and it will be a blind procedure. You can just turn the tip of the phaco probe bevel down. That will help to increase the efficiency and reduce the chances of catching the iris during surgery. And emulsification should be done in the central safe zone away from the pupil. Use a good quality viscoelastic such as Elon GV or highly cohesive viscoelastic which will push away the pupil. Now, other steps that you can be done is the retraction of the pupillary margin. This can be done either by using a dialer in the other hand, and also the last quadrant should be done in the anterior chamber because there is a very high chance of PCR at this stage. Use a good dispersive viscoelastic to protect the corneal endothelium at this part. So cortical aspiration should be remembered that ruptures occur very commonly because the rectus margin is not visible. So when you do bimanual irrigation aspiration, you can use the irrigation probe to retract the pupillary margin and the aspiration to do a much thorough job of cortical cleanup. Many a times, cortical remnants do remain back in small pupils. So some few firsts for the phacoemulsification part is that one is a thorough preoperative examination should be done. And always check and see what is the maximum dilatation possible. Use the medication which will give the maximum dilatation. Even if you have to use ibuprofen, it is better to be on the safer side. Consider use of adrenaline, which is intracamerally used in the anterior chamber. It can also be used into the bottle of BSS. Use a good viscoelastic, cohesive viscoelastic, give you viscodilatation and helps during surgery. Number of techniques which are described, including the use of iris hook, ring, paniculitis, all of these will help, and always keep the parameters on the lower side. Now, I would like to share some videos at this point of how we can definitely use. So one of the video is the iris hooks which I'm showing over here. Here you can see we have a small pupil. Iris hooks help in a way that you can titrate the amount of dilatation you need. The advantages which can be used as compared to rings is that it can be used in coloboma cases where rings may not be possible. The only disadvantages is multiple side ports need to be made, so there can be a leakage of fluid. The iris hooks are made of proline and have a silicone stopper. The silicone stopper helps to titrate the amount of dilatation which is required. So initially you put the dilatation which is required and gently retract, and you can see the silicone tube rest at the side port and gives you the amount of dilatation. Always nice to use opposite side first, and then you can titrate the amount of dilatation. The end result is a square pupil, and this gives you a good amount of visualization to proceed with surgery. So this is one of the advantages. The iris hook is a cheap alternative and can give you good visualization. So here you can see you have achieved a squarish rectangular pupil at the end of the procedure. Now I would like to show you the other surgery of using a Malugin ring. In a smaller pupil, especially in patients who have ISIS or intraoperative floppy iris syndrome, patients on Durimax, patients on tamsulosin, you need to be aware that the pupil dilatation will come down during surgery, and also the pupil has a tendency to come into your phaco probe. In these cases, a Malugin ring, a Bhattacharjee ring, or one of the ring devices help a lot to the pupillary margin and more chances of the edge of the iris being caught during phacoemulsification. When the ring device is known to stretch the pupillary margin and keep it away from the iris and the phacoemulsification probe. So here we can see we put a Malugin ring. It has an 8-point of fixation, 4 points being provided by the ring itself, and the remaining 4 points provided by the shaft of the joining the two rings. So here you can see once the ring is in place, we achieve about a 5.5 mm dilatation, and then the surgery can be carried out without problem. The next case which I would like to discuss is a case of a festooned pupil due to chronic uveitis. You can see there are plenty of posterior synechiae over there. It's very important to use the dilatation of either by using visco or by using adrenaline. So initially stain the cataract before you use any of the viscoelastic, otherwise the capsule will not take up the stain. Here we can see the synechiae are being released. There are some areas which are not stained because of the presence of the synechiae. We are then using the dye again, trypan blue, and once that is instilled in the eye, you can easily wash it out and put adrenaline, and here you can see that you have a large pupil to dilate, and this helps you with the surgery. So it's very important to sometimes use a combination of techniques, and that will give you the best results. Thank you once again, Cortical, for giving this opportunity.
Thank you, Dr. Savio, for the wonderful talk. The next talk will be on management of PCR by Dr. Preeti Manjunath. She is the Director and Chief of Cataract and Refractive Surgery in Netra Eye Hospital.
Hello, everybody. First, I would like to thank all the KOS committee members and Dr. Nagaraju to give this opportunity to me. And today I will be discussing on an important topic, that is posterior capsular rupture. What next? Posterior capsular rupture is a problem which cataract surgeons do face sometime or the other, and a meticulous knowledge about how to manage this problem is of utmost importance. Some of the predisposing factors can be like a posterior polar cataract, which has an inherent thin posterior capsule, small pupil with pseudo exfoliation, or anything which decreases the visibility, like poor illumination or corneal opacity, corneal scar, traumatic cataracts, especially the penetrating injuries, and very hard cataracts, especially because they require more manipulation and maneuvers for removal of the cataract. Any of these, when you find any of these predisposing factors, it is important to discuss with the patients prior to the surgery about these conditions. Now, when is a PCR likely to happen? PCR can happen during any stage, right from sculpting till the IOL implantation. But some of the more likely stages of cataract surgery where this can happen is phacoemulsification of the last nuclear fragment, especially because there is nothing much between this nuclear fragment and the posterior capsule. And there is a tendency of the surgeons to pull out the phaco probe out of the eye while removing the last fragment. So it is very important to always inject enough viscoelastic and push the posterior capsule behind while doing the emulsification of the last nuclear fragment. Irrigation, aspiration, and polishing of the posterior capsule should be very gentle always. And hydrodissection should also be very gentle because these things can cause a PCR. IOL implantation while doing should be gentle, and you should be very sure that the bag is well inflated before implanting the IOL. There are some signs which might indicate that a PCR has happened when you are operating, like a sudden deepening of the anterior chamber, a small pupil suddenly dilating during the surgery, or the nuclear fragments cortex was aspirating, fragmentation, everything was going on very well, but suddenly there is a difficulty in followability of these things, then you can suspect a PCR. Some of the obvious signs are like disappearing of fragments from the view, or tilting of the fragments, or obvious PCR which is seen, and vitreous loss which is seen. So these are the signs indicative of PCR. When you know that there is a PCR, the most important thing is to stay calm. So a very well calm and composed surgeon can definitely handle it beautifully with very good post-operative results. The management aspects include keeping the rent as small as possible, removing the nuclear fragments as safely as possible, and limiting the vitreous loss to the maximum possible. Now, the aim to prevent enlargement of the PCR and loss of vitreous is don't come out of the anterior chamber whenever you suspect a PCR. Stay in is one of the most important steps. So what happens if you suddenly come out and remove all your instruments is the anterior chamber collapses. The fragments can go into the vitreous, and the vitreous can prolapse into the anterior chamber, as well as the rent can expand. So when you stay inside and keep the chamber formed, you can switch to irrigation mode and start injecting viscoelastic from the opposite side. Now this viscoelastic will help to push the vitreous back. It will temporarily tamponate the posterior capsular rent and also push the fragments away from the rent. So once the viscoelastic is injected, then we can remove the instruments from the eye. The management depends upon the stage at which the PCR has occurred, the extent of the PCR, whether it's small or large, whether it is associated with any other problems like zonular dialysis, is there any vitreous loss or not, and is the anterior capsular rim intact or not. The expertise and comfort of the surgeon in different surgical techniques is very important to decide on the next management course. It is also very important to watch your words when you are managing this, because always remember the patient is listening under the cover. So removal of the nuclear fragments has to be done very safely. If the nuclear fragments are very large and you're comfortable with a manual procedure, don't hesitate to convert into a manual small incision cataract surgery. But if you're doing a phacoemulsification and you're comfortable, then use short bursts of low energy ultrasound with all the parameters low to remove these nuclear fragments. So when the nuclear fragments are close to the rent, inject enough viscoelastic, push it away from the rent place, and then emulsify these fragments. Don't chase the disappearing fragments. The fragments which you see are going into the vitreous, don't try to fish them out because this can cause vitreous traction and retinal detachments. So the posterior segment surgeons can beautifully handle it and give good postoperative results. The management of vitreous is a little tricky because many a times it is very difficult to see whether there is vitreous or not because it's transparent. In case of any doubt, always inject diluted triamcinolone acetate in which the vitreous strands become pretty visible, and then vitrectomy can be done. Anterior vitrectomy is a common procedure which is done by the anterior segment surgeons, and during anterior vitrectomy, always stay inside the chamber, in the center of the chamber, don't move around. Always use the cut IA first rather than IA cut. Now the cut IA mode helps to cut the vitreous and separates it from the rest of the vitreous body, and then the irrigation aspiration aspirates the vitreous out. If you use the IA cut first, then what happens is that vitreous gets pulled, more and more gets aspirated, and more vitreous loss happens. The second thing is the irrigation should be slow and it should be less because the vitreous tends to absorb the water and swell up, increasing the loss of the vitreous. So once the anterior vitrectomy is done, you can always inject the triamcinolone acetate again to find out if any more vitreous is still there. Pars plana anterior vitrectomy is a more ideal procedure because you are behind the posterior capsule, and in this case, the prolapse of the vitreous is prevented. In fact, the vitreous comes down into the vitreous body, and being more ideal, it should be done, but it requires a very specialized training, and you should do it only if you are trained for this procedure. The cortex has to be removed preferably by a bimanual method rather than a coaxial, because in coaxial continuous irrigation happens, which leads to hydration of the vitreous. So a bimanual method also helps you to remove the cortex in different positions much more easily. Again, all parameters should be low and the bottle height should be low. You should aspirate the most prominent vitreous and the anterior leaflet, most prominent cortex and the anterior leaflet of the cortex as far as possible, away from the posterior capsular rent and the edges. The cortex which is close to the edges should be removed only at the end. So once you have removed the nucleus fragments, managed the vitreous and including the aspiration of the cortex, then comes the IOL options. What are the different options available? If your PCR is still small and central, you can still implant an IOL in the bag, and especially with a good memory IOL so that they open up very slowly. If you have a large and an irregular PCR, and if your anterior capsular rim is good, then you use a sulcus 3-piece IOL. Now, if you have a very big capsular PCR, as well as you have other problems like zonular dialysis, or you don't have a good capsular anterior capsular rim support, then you can consider other options like iris fixation IOL, scleral fixation IOL, as well as AC IOLs. So all's well that ends well. When you are closing the case, see to it that all viscoelastic is removed. You should be very sure that there is no vitreous in the anterior chamber as well as in the wound. IOL is stable. All the wound, closure is watertight. Subconjunctival antibiotic steroid injection should be given, and the inflammation and intraocular pressure should be controlled properly, immediate postoperatively and later as well. Detailed posterior segment examination has to be done during the post-op visit to see if there are any fragments behind. Now, posterior capsular rupture, if managed meticulously, has very good visual outcome. The mantra is to stay calm and composed, assess the situation, and act accordingly. It is a situation which we should be prepared for, but pray we do not have to face it, and that is PCR. So thank you so much to everybody for a patient listening. Thank you so much.
It was an excellent compilation of talks. I thank Dr. Shilpa for speaking on phaco-dynamics, Dr. Soumya, pediatric cataract, Dr. Savio, small pupil and PCR management by Dr. Priti Manjunath. We have here with, we'll be trying to compile the questions. Dr. Srinivas, our assistant professor, and Dr. Shweta are here. They are excellent cataract surgeons and pediatric cataract surgeons. They'll be giving some inputs.
Suppose, say we have done a thorough vitrectomy, still post-op you will find a few vitreous bands in the anterior chamber. How to manage such? So when such scenario occurs post-operatively, we see a lot of cases even after thorough vitrectomy. Some fibrous vitreous bands will be left floating in the anterior chamber, but not touching the endothelium. Such can be left, and over a period of time, they get liquefied and disappear. Only thing is, risk of CME will be there. You have to manage with the long-term nafafenac eye drops.
As far as the pediatric cataract management is concerned, so unilateral cataracts are more amblyogenic than bilateral cataracts, as all of you know, and most of the times in Indian setting,
If I
there
could
will be a
just
late
add on,
presence.
this is Dr.
So most of the children would have ended up in squint or nystagmus. So as far as possible for unilateral cataracts, so if the corneal diameter is more than 8 mm, so it's better to place the intraocular lens around 1 year of age. So if it is bilateral, then we can plan bilateral lens aspiration with cataract, IOL implantation after 2 years or in the same sitting. So, but unilateral cataract management should be more aggressive with post-operative patching and other refractive rehabilitation.
And I have got a few of interesting scenarios where you have not blocked the visco cannula properly or hydro cannula properly. When you want to do a visco injection or a hydro polish, the loose needle will try, like it will go and hit the posture capsule. That should be carefully monitored. You should lock the needles. Even though you have done a very good surgery, when you are doing a hydro wash of the capsule, if the loose needle is there, it will just go and hit the PC and cause a PC rent and vitreous loss. So that should be.
Thank you, Dr. Srinivasa, for the wonderful practical tips that you have given us on phaco.